Before we begin, a quick disclosure. This podcast is sponsored by Innovative Hematology Incorporated, a leader in blood disorder care, education, and clinical research. Innovative Hematology may have direct or indirect financial relationships with some of the organizations, products, or companies discussed. Full disclosure and details can be found in the episode show notes. Welcome to We Bleed Too, where women's health meets real talk, real care, and real expertise. Hello, everyone, and welcome to We Bleed Too. My name is Magdalena Lewandowska, and I'm joined by Hilary Gaudreau and Janey VanLiew.
The unique thing about our podcast is that we have different perspectives from a hematologist, an obstetrician, and from a registered nurse. If you're somebody who maybe is not thinking about having children anymore, what are some other steps that we can maybe take surgically that can help us to decrease our menstrual bleeding or not have any bleeding at all?
Thanks for asking that, because it also brought to mind progestin IUDs are not just for menstruating women. I'll throw that out there. We can circle back if we ever have time. So there are options. And so for someone who has completed their childbearing, another option is a procedure called an endometrial ablation. An endometrial ablation is a procedure where the lining of the uterus, or the endometrial lining, just the thin lining on the inside of the uterus, is treated in a way that prevents it from regrowing month after month. For a lot of women, they will stop having menses altogether. It's important to know, though, that this procedure is not contraception, and no one should become pregnant afterward because that can be a very dangerous pregnancy. But an endometrial ablation is a really great option for women who don't want and shouldn't have. Are you saying that you've had an ablation?
I sure did.
Congratulations.
When I thought I was like hemorrhaging monthly and went to my doctor, my OBGYN, several times, went into the ER and was basically told this is normal for you. And so eventually, once I was done having babies, was like, okay, please ablate my uterus.
The question is, have you had a bleeding disorder workup?
We'll come back to that on the break. Thank you for sharing that, Janey. And I'm happy that your ablation procedure worked so well for you, and you deserve that. It's not perfect for everybody. And just like life, we go through a trial and error process. If someone has an ablation and it's not effective for them, then, we have to look at the underlying reason why someone's having heavy menses. And sometimes it can be multifactorial. It's a bleeding disorder and it's uterine fibroids, or it's a bleeding disorder and something called adenomyosis, which affects the muscle of the uterus. So there's a procedure called a uterine artery embolization, and that's performed by an interventional radiologist. And that is another minimally invasive technique that treats the uterus without removing the uterus to decrease menstrual blood flow or menses or bleeding in altogether from the uterus. And then finally, there are techniques to remove polyps or fibroids, benign muscle tissue, tumors that can impact bleeding. And lastly, we still have hysterectomy, or removing the uterus in its entirety, or the cervix and the uterus. And it's important to know that when we talk about hysterectomy, that does not mean removing the ovaries, because that's another myth that's out there. When someone has a hysterectomy, that all of their hormones go away. And it's important to know that hysterectomy refers just to the uterus. It doesn't refer to the ovaries. Sometimes the ovaries do need to be removed, but it's worth a conversation.
So it's a separate word, the bilateral salpingo-oophorectomy, right?
You said it perfectly.
And that's an important thing. So it is possible to leave your ovaries in when you just take the uterus out.
Absolutely.
So you don't put somebody into premature menopause.
Exactly.
I love about our clinic is that, it takes that shared decision making, and we're able to make that all during one patient visit. And so what about like our patients that maybe don't come to a women's clinic where they have gynecology and hematology? Where should they start? Should they start with their gynecologist first in this discussion? Should they talk to hematology first to see if there's surgical interventions that are best for them, or what do you recommend?
Understanding the options in whatever way, whoever they feel most comfortable with. Ultimately, it's about knowing and advocating and making sure that everybody is on the same team. And I'll also put in a plug, for any kind of surgical procedures, especially for somebody with a bleeding disorder, or who's on anticoagulation for a history of blood clots. It's really, really important to involve your hematology team because there's specialized management in those situations. So we want to make sure that we don't cause that additional harm. And so here we actually encourage our patients to tell us what the dates are. If it's not Dr. Gaudreau, which we know obviously if Dr. Gaudreau does the surgery, but if it's another surgeon or gynecologist, we ask our patients to call us. And we have a dedicated team to help manage that. I understand we're very, very fortunate, and this is not the reality many people face. I would encourage whoever has a clinic that has a combined program to try to check it out, because I think especially for patients who have a bleeding disorder, it's just so poorly understood in many places in the community. It's always nice to get your care in one spot, but I don't think there's a perfect answer as to who to talk to first. I really think it depends on your comfort level and the individual expertise. But I always say, knowledge is power. So the more that we understand about our own bodies and about our options, and even for women listening to this, we're happy to post resources. I think that's the key behind shared decision making.
And when speaking about women's health, sometimes there's other things other than just heavy menstrual bleeding. So things like endometriosis or even PCOS or adenomyosis, speak a little bit about that and what that means for women's health, especially in particular towards our women with bleeding disorders.
It's not always the bleeding disorder that's causing the bleeding.
Correct. It can be layers of diagnoses. Yeah. And sometimes a woman's bleeding disorder symptoms in terms of her menstrual health can be stable for years and then start to change. So we know that bleeding disorder is impacting that bleeding, but also, to your point, Janey, other conditions can develop or impact it. So something like PCOS or polycystic ovarian syndrome, which technically is called metabolic syndrome, which is a much more appropriate diagnosis, but that term hasn't really caught on. So I try to use all of them, so people are familiar with all of them. But that condition is characterized by irregular menses or skipped menses. So what's happening is when a woman who is not being treated hormonally is missing a menses, say 1, 2, 3 months in a row, the lining of the uterus is accumulating. It is thickening during those months. So when she does ovulate and does have a menses, the amount of tissue is so much heavier and the bleeding is so much heavier that is a reason for some women to end up in the emergency room to seek care, because the PCOS or polycystic ovarian syndrome is definitely associated with heavier menses and even some menses that require immediate medical attention. Endometriosis is interesting because we know that it is associated with irregular bleeding and sometimes heavier bleeding. We're not entirely sure why or what the mechanics are or the pathophysiology of that is, but sometimes when we can get the bleeding aspect of someone's symptoms well controlled, the pain part of it can be difficult. And it's just important to kind of expand our thought process and not see patients as a diagnosis, but to understand that there are many factors contributing and being open to treating, discussing, evaluating for other factors.
Like imaging too, right?
Absolutely.
I feel like I see you order a lot of ultrasounds in our patients when there's a change, especially if it's really important from a cancer perspective. If you stopped menstruating, for example, and going into menopause, and then you develop abnormal bleeding, and we'll cover this more in another episode, but that's a really important thing to be mindful of your body if there is a significant change.
Absolutely.
It's important to talk to your doctor about it.
So pelvic ultrasound is the ideal imaging modality for most gynecologic conditions. So it can detect things such as a polyp, which is a benign tissue growth inside the uterus, which can really cause a lot of heavy bleeding. They're small but mighty. Uterine fibroids or leiomyomata, which are dense muscle tumors that are benign, not cancer, but can cause bleeding issues. And then there are conditions such as endometriosis that cannot be detected with pelvic ultrasound. So
how do you find that out?
That's a great question. So from a standpoint of endometriosis, the single best way to evaluate someone is based on their clinical history and their symptoms. So we give people a clinical diagnosis of endometriosis. If someone has a pelvic ultrasound and they have endometriosis that has collected in a large enough cystic structure, we call that an endometrioma. That can be diagnosed on ultrasound. However, I tell patients, if you have if you're told your ultrasound was normal, your pelvic ultrasound was normal, it doesn't mean that you don't have endometriosis. We tend to treat people as though they do have endometriosis because medical intervention, we always prefer medical intervention due to its lower risk profile to surgical intervention. However, if we're treating someone as though they have endometriosis and it's still not getting better, then finally the next step, typically the last step, unless someone is attempting pregnancy, is to perform a laparoscopy or a surgery where we take a small camera and look inside the person's pelvis and we look for visual evidence of endometriosis. And that not only allows us to establish a diagnosis, but then we can remove it at the same time, which treats it as well. So having that diagnosis firmly kind of cemented and then being able to establish the extent of the endometriosis and then remove what can be removed is also part of it.
And one of the things that I see with some of our patients that come in that are, on the adult women's clinic side is that many times whenever I'm calling and doing their intake and going through their history, and maybe they don't even always realize that they had heavy menstrual bleeding because as an adolescent, they were put on some sort of hormonal control. So usually upon that discussion, especially if they're a new referral coming in, it's like they start kind of putting those little pieces together, almost like a puzzle. Because I'm like, well, you didn't have heavy periods when you were younger, or, how were your periods? And they're like, oh, they were fine. Okay, well, were you on hormonal therapy? Yes, actually, I was on, some sort of birth control. I can't remember what the name is, but that actually did help my periods. And then they get to the age where they're having children. So maybe they have 2 or 3 back-to-back pregnancies where they're not having really regular menstrual cycles and not putting 2 and 2 together that they're heavy. And then they kind of reach that 40-year-old age and kind of perimenopausal and the return to heavy menstrual periods. That kind of comes up of oh, well, this is why I got the referral now I'm having these heavy periods, but maybe they didn't realize that they've always had this bleeding tendency. So what's your thoughts on that?
I think that's such a good point that you make, because if we don't ask the right questions, we make the assumption that the heavy menstrual bleeding is a new diagnosis. And when we think of it as a new diagnosis, we don't think of an underlying bleeding disorder as being part of that reason for that bleeding. To your point, what I hear you're saying is you ask those questions. When someone says, my bleeding just became heavy, well, then we have to ask, why wasn't it heavy before? And a lot of patients don't realize that they've used some form of contraception that has minimized their bleeding until they were ready to have children. And then pregnancy, obviously, is 10 months of no menses.
And they're breastfeeding.
Breastfeeding absolutely can suppress ovulation and diminish bleeding. And typically it becomes a woman's burden to contribute the contraceptive aspect to a relationship. And when a person's family is complete, that's when women finally feel like they're able to wash their hands of hormonal contraception. And it's because that's the first time in their reproductive lifetime that they are no longer utilizing hormonal methods for contraception, which also brought with them unwittingly, unknowingly, but wonderfully, control of their menses.
I think that's a really important point, Janey. That's where also the other aspects of the bleeding questionnaire that you kind of talk to our patients about is really important, because what are the other bleeding symptoms? I mean, in terms of the deliveries themselves, the risk of heavy menstrual bleeding, it goes beyond the risk of heavy menstrual bleeding. So for example, when women who deliver babies and have a lot of bleeding, either with the delivery or after, I mean, typically in von Willebrand disease, for example, we'll see a higher risk of hemorrhage about a week later when the von Willebrand levels start to normalize. Or sometimes women just have heavier bleeding for beyond the 6 weeks postpartum, which is what we call prolonged lochia, which women, people at least can remember, by the time I saw my OB again for a follow-up visit, were you still bleeding? And if the answer is yes, and it continued for 6 months, I mean, that's not a normal amount of blood loss. But I will also point out, when we talk about the different barriers that women face beyond, for example, even bias and exclusion from clinical trials, to not understanding fully what normal is, right? Because of it. They also face the added barrier, and there's so many psychosocial responsibilities. There's the responsibility as still a primary caregiver. I mean, we saw that during COVID, right? Like women, for example, were more likely to be the primary caregiver for children than men, even though there were dual working households, right? Even in those settings. So, I mean, I feel like as women, oftentimes we tend to ignore certain symptoms in order to provide that care to other people around us, like especially within the caregiver capacity. So finally, absolutely, like the kids get bigger. There's no longer a reason to completely ignore what's going on. And I feel like that's sometimes when women do seek medical attention.
When we get to ascend on our priority list, then we have the bandwidth to then focus on seeking answers for the problem, or we have the bandwidth to even understand that there is a problem. But otherwise, when we're in that postpartum and the first several years of our infant children's lives, we're in survival mode. So we don't even have the capacity sometimes to fix our own problem. We're just trying to stay alive, and while we're fixing everyone else's problems because those feel much more pressing. Plenty of patients have come to us and told us that their doctor has told them that it is normal to bleed for longer than 6 weeks after delivery. And that's unfortunate.
Well, and I think that's a big part. You know, there's a lot of organizations who have made it their mission to educate healthcare professionals, and that includes the Foundation of Women and Girls with Blood Disorders, where actually our clinic is a model for that. It's a Learning Action Network clinic, which combines hematology and gynecology to provide that comprehensive care. But really, FWGBD has so many resources available, and they're free and they're online. And also the National Bleeding Disorders Foundation also has that as a mission to make sure that we're providing education both to patients and to healthcare professionals. A part of it is education. A part of it is just the systemic bias that exists. And a part of it is there's so many psychosocial barriers still that we have to overcome to really provide that comprehensive care. And I will say, you know, for women specifically, getting their buy-in, you know, a big question that comes up, like here, we're a hemophilia treatment center. And so for our women affected with bleeding disorders, a question that comes up at our regional meetings is, how do we get women to come? Right? They're busy. They have a lot going on. As you mentioned, they deprioritize themselves on the list. And it's really not until they have additional issues with the surgery or with a bleeding complications that we hear from them, or if they're pregnant, but then it's usually because they're worried about the baby.
Yes. One approach that I sometimes take with patients is to remind them that their health translates in, you know, to their children's health. So as mothers, we deprioritize our own health and we put our children up here. I try to remind them that in order for them to be the best kind of mom they want to be, whether that's having the energy to play with their kids, having the patience that we all need with children, having the functioning mental capacity that we know can be impaired by iron deficiency and anemia, all of the things that help them be healthier, allow them to be better moms. And that tends to resonate sometimes. Do your children deserve the best version of you? Well, of course, no one is going to say no to that. And sometimes that clicks with us, that resonates in a way that then motivates us to make ourselves a priority. But it tends to be in a more selfless type of way. There are so many burdens and stressors that women face. It's easy to write off a lot of symptoms as related to work, children, et cetera, et cetera. So the bleeding aspect doesn't always get their attention. Personally, I think that having someone external validate the need for their care is important. So sometimes that's their own mother, a neighbor, a friend. But when a healthcare provider takes the 2 seconds that it takes to validate that person's symptoms and to say, you need to do this, sometimes there's a light switch that's flipped on, because as women, sometimes we don't fully trust our own assessment. And we're also afraid to waste someone's time, to go to the doctor with a symptom. What if that doctor says, I'm fine? And then there's this sense of, well, I just wasted their time.
Well, it's a systemic problem. Women had been ignored and unfortunately excluded from trials for so long. They're used to it. And that you're less likely, if you're told over and over again, this is normal, you're fine, you're a lot less likely to seek additional care because you've had really negative experiences in the past. If you don't get the care that you deserve, if you're not diagnosed, in a timely fashion, we really want to minimize that time, like from the onset of symptoms or even before the symptoms happen in a family history of bleeding disorders, because we want to make sure that people get the care they deserve and that for our women, before there's a chance for complications to arise, like we want to be prepared because that knowledge is powerful, and it will help them make better decisions for themselves. And one of my favorite medications, in the hematology world to give, for people is IV iron, because there are so many women who benefit from it. And really, about a month later, they get this like wonderful increase in energy. And they're like, wow, I didn't realize I was feeling poorly until I felt better.
I am just beyond thankful to work with both of you and appreciate that you guys are there. We're just beyond thankful to have other women and that listen to their patients. And it's such a pleasure working with you guys, and, happy to continue this discussion.
Vitamin manufacturers started including DHA in their prenatal vitamins.
I hate this term, geriatric pregnancy.
In my brain, I think of like this woman who's pregnant with like a walker, it's like...